Good afternoon, everyone. This is a very powerful session, I see, and I'm happy to have you all here. Talking about the stiffness with rotator cuff tear, actually, the concomitant stiffness with rotator cuff tear is a sophisticated territory of controversies, and even dealing with this problem with the paradox of fix and move, fixing the cuff and moving the glenohumeral joint, makes some surgeons think that even it's a myth to have this combination, or it's just a theoretical postulation, and there is no such problem in the actual clinical practice. To start with the size of the problem, we all know that the rotator cuff ranges about 20, the incidence ranges about 20%, that rise up to 70% with ages more than 70 years of age. So, but the concomitant stiffness, and this recent study found that the incidence may be up to 10% with the partial thickness rotator cuff tear, and rises up to 40% with the full thickness rotator cuff tear. This is a huge percentage. So, of course, there is a problem with the perception of the problem. So, this problem of the perception is bifactorial. First, we must know what is the definition of the stiff shoulder. And if I ask all the surgeons in the room, what's the definition of a stiff shoulder, I think I will not have two identical answers. So let's agree about a consensus about what is stiff shoulder. It is the limitation of passive range of motion, again, passive range of motion below 100 degrees in the forward flexion and 30 degrees in external rotation. And the second factor, that when we have a frank rotator cuff tear with limited active upward flexion and abduction, and frank MRI picture of full thickness rotator cuff tear, actually we don't do the further step of having a look on the passive range of motion. Please spend a couple of minutes to examine for the passive range of motion to pick up this kind of patient. And of course, just as a reminder, the frozen shoulder is the idiopathic, while the stiff shoulder is the secondary one to other etiology. So what's the source of pain? What's the source of the stiffness? Why a rotator cuff tear, which seems by logic that the joint is actually moving more, to have stiffness? Maybe due to pain, maybe due to the disuse of the joint, the weakness of the muscle, and the surgery itself. It is a range limiting procedure that limits and tightens the joint of the glenohumeral. Or maybe due to a post-operative immobilization, long immobilization, or suboptimal rehabilitation program. And so we have a stiffness secondary to the rotator cuff due to the pain and the disuse and so, and the stiffness after the repair. My focus in this talk is about the stiffness secondary to the rotator cuff tear. And I must remind that all the predisposing factor of the frozen shoulder, it works as well in the stiff shoulder, like the diabetes, the thyroid, the cervical problems and procedure, the cardiac problems and procedure. And the pathology as well is like the primary frozen shoulder. We have the fibrovascular infiltration, the hyperemic synovitis, the capsular thickening, the cytokines, many cytokines in the joint space, and in the also the ICAM, which is the intercellular adhesion molecule, which has a connection or a relationship with the high glucose level, and this may give us some clue why this problem is more to occur with the diabetic patients, together with the high fibroblast and the second vessel wall. The third debate is the approach of management. Previously, we do the physiotherapy before surgery to regain the range of motion. But actually, the recent studies found that the physiotherapy before surgery actually regain or improve the scapulothoracic range of motion more than the glenohumeral. And the expanding some time with this physiotherapy may have the risk to increase the tape size, the muscle atrophy, and muscle degeneration. Recently, the studies showed that a concomitant release with the fixation of the cuff have more satisfactory results, better range of motion, and faster recovery for function. Fourth debate, what to release? It's the same, but we release the rotator cuff, the rotator interval, cranial ligament, anteroinferior capsule, middle glenohumeral, and inferior glenohumeral ligament. But the posterior capsule actually, again, the evidence showed no further benefit of doing a posterior capsular release. So till 7 o'clock is quite enough. Release with the rotator cuff repair. The last debate is the rehabilitation program. Again, traditionally, the debate between the traditional way of rehabilitation, which is the early range of motion that is promoted to prevent stiffness once again, especially in the prone patients for stiffness. But recently, studies showed that 4 weeks of strict immobilization showed better pain control and better healing for the cuff without causing serious stiffness, especially if you have a look on your patient 1 year after surgery. Some studies go further than the 4 weeks till 8 weeks of immobilization, but again, this showed no extra benefit than the 4 weeks immobilization program. So my take-home message, it is not uncommon problem to have stiffness with the rotator cuff tear. But stiffness, you must keep in mind that it is the limitation of passive range of motion below 100 degrees forward and 30 external. One-stage procedure of release and rotator cuff repair is promoted. Posterior capsular release is controversial and it has no extra benefit. And again, early passive range of motion is not that beneficial for this kind of patient. Thank you.